inviting me to speak on this topic of targeted therapy in non-small cell lung cancer. Before I start, I have three admissions. I'm not going to tell you anything new. These distinguished professors, consultants, and experienced clinicians, they know, I bet, they know more than me about this topic. My aim today is to refresh our collective knowledge and to share what I do in my practice. The number two admission, that this is a very comprehensive subject. So I would like to try to squeeze in as many slides as possible within the limited time. And number three admission, that some of the slides are really very boring, but some of them may be quite exciting and interesting. So just bear with me. So we start with the targeted therapy in non-small cell lung cancer. Over the past 2 years, 2 decades, we have witnessed that non-small cell lung cancer evolved from a disease defined by histology only to one driven by molecular precision. Today, identifying actionable mutations isn't just an option at all. It is the foundation of personalized treatment. Now, we move to the next slide. This slide is quite busy slide. This slide illustrates the complex signaling network of the EGFR receptor family, which includes EGFR1, which is HER1, EGFR2, EGFR3, and EGFR4. All are called HER2, HER3, and HER4 as well. When activated by the ligands such as EGF and TGF-alpha, these receptors dimerize and trigger multiple downstream cascades. These pathways, usually we follow the three pathways, RAS, RAF, and MEK pathway driving cell proliferation and differentiation. The number two is PI3K and AKT pathway, and then the MEP-STAT pathway. Now we move to the third slide. This slide shows the driving mutations. As we know, that the driving mutations in the non-small cell lung cancer on the left side shows environmental and genetic factors. Along with the aging-related DNA damage and p53 inactivation, which is a critical step in tumorigenesis. On the right, on the other side, the diagram shows major oncogenic driver mutations that define distinct non-small cell lung cancer. These include EGFR, ALK, ROS, MET, RET, BRAF, you name it, you have it. Now we move to the third slide, which shows that there is a driver mutation in the early stage non-small cell lung cancer. Several key driver mutations guide targeted therapy approaches. EGFR mutations are seen in about 15 to 25%, particularly in Asian, female, and non-smoking patients, and are the most actionable, clinically actionable, as shown in the ADORA trial we will be discussing in a second. ALK rearrangements occur in a lesser percent, around 3 to 5%, typically in younger and non-smokers. KRAS, which is the most common one, including G12C, represents the largest group, about 25 to 30%, some say 35%, and is more common in the population. So we go and we discuss the molecular testing and diagnostics. So when we are talking about the comprehensive molecular profiling, which is the foundation of precision oncology in non-small cell lung cancer. Using the next generation sequencing and ctDNA, we call it a liquid biopsy as well, we can detect actionable mutation like EGFR, ALK, ROS, RAF, RET, MET, and KRAS. These results guide first-line targeted therapy and allow real-time monitoring of the patient's response and resistance. With their high sensitivity Although the ctDNA sensitivity is a bit moderate, it is around 0.69, but specificity is very, very high, almost 99.8%. We can test these things, monitor these patients during the treatment, and then treat them accordingly. Now, you must be wondering, especially the young doctors here, what is a targeted therapy? Why are we giving this targeted therapy? Targeted therapy represents the essence of precision oncology. It focuses on specific genetic alterations driving tumor growth, such as I have just mentioned, EGFR, ALK, ROS, BRAF, while sparing normal tissue. Unlike traditional chemotherapy, which kills each and everything, does not distinguish between good and the bad cells, this treatment are highly selective and can be used alone or with chemotherapy or even immunotherapy in some cases. The mechanism of targeted therapy works by blocking the specific oncogenetic mutations. As I've been telling you about this EGFR, ALK, ROS, and BRAF mutations that drive the tumor growth. They act through two main mechanisms. Number one, inhibiting mutant kinases. Number two, restoring apoptosis. By inhibiting mutant kinases, they stop cell proliferation and then restoring apoptosis, leading to the cancer cell death. This precise approach not only halts tumor progression, but also spares normal cell tissue, making a major advance in personalized care, cancer care. This slide again is very busy slide. This slide shows that the key genetic drivers in the non-small cell lung cancer and how targeted treatments have evolved. Most common, which we are using in my practice, are EGFR and ALK alterations, followed by KRAS, ROS1, and BRAF, and others. The timeline on this one shows from how from 2011 onward, how targeted therapy from early ones like the erlotinib and crizotinib and gefitinib, new agents have emerged like osimertinib, which we are using now, sulfatinib, campatinib, and all these things we have been using. Finally, the liquid biopsy, the ctDNA, is the main thing in the diagnosis and the treatment monitoring. At the moment, there are so many trials going on as to whether ctDNA liquid biopsy is good enough to monitor the growth of the tumor rather than doing the regular CT scans, which we do it on 3 or 4 monthly basis. We move to the targeted therapy treatment for non-small cell lung cancer. This slide highlights the range of actionable mutations in non-small cell lung cancer and their corresponding targeted therapies. For EGFR and ALK to ROS and BRAF and RET and MET, pathway now has the specific inhibitors that have transformed patients' outcome. I have just mentioned that we have osimertinib for EGFR mutant patients, alectinib for ALK-positive patients, sulfatinib and campatinib. Not only improves survival, but quality of life. This is the most important thing. Most of the patients who live with the cancer, the quality of life is so poor, so appalling, that they are just leading the life by the bedside. On the contrary, these treatments have revolutionized the mechanism and the outcome and the outlook of the patients suffering from the breast cancer, from the lung cancer. And I'll be discussing a couple of my patients, my own practice, my own experience as to what did my patient do being on these treatments. We are going to talk about couple of the patients who have been treated with the adjuvant targeted therapies. So these two slides highlight how molecular profiling now shape adjuvant management in early stage non-small cell lung cancer. Our first patient on the left side, she's a 60-year-old female patient. She was diagnosed with stage 2 EGFR mutant non-small cell lung cancer. She underwent surgery. She had a good surgery. She recovered within no time. She was referred to me for adjuvant systemic treatment. Given that she was a stage 2 disease, after giving the chemotherapy, I gave her adjuvant osimertinib, being that she was EGFR positive. And this was on the basis of the very standard ADORA trial, a landmark study, and we will be discussing in a couple of seconds. On the second case, on the right-hand side, this gentleman, 55-year-old gentleman, he was diagnosed and treated with surgery for stage 2B ALK-positive non-small cell lung cancer. As with the previous case, after the curative surgery, he was referred to me for consideration of adjuvant systemic treatment. He again had targeted therapy. The difference is between the two I'm going to discuss in the following slides. Then there is another patient. She was 65-year-old. She was diagnosed with ROS1 stage 3 disease. She underwent surgery. She made a good recovery and was referred to me for consideration of adjuvant systemic treatment. So 3 patients, one with the EGFR positive disease, the other one with ALK positive disease, and the third one with ROS positive disease. And 3 different treatments. This case highlights how precision oncology is transforming lung cancer management, where molecular profiling right at the time of the surgery is making the decision easy for us. We move to the first patient who was diagnosed with EGFR positive disease. We are discussing the very famous landmark study called ADORA study. ADORA has completely transformed how we treat early stage EGFR positive non-small cell lung cancer in resected stage 1B to stage 3A. 3 years of adjuvant osimertinib dramatically prolonged disease-free survival with the hazard ratio of only 0.17. Which nearly doubled the 2 years disease-free survival compared with the placebo given after the chemotherapy. So it has doubled the disease-free survival time. Importantly, it cut CNS recurrences. Every single patient who has had surgery done would, at some stage of his life, would come to me with the brain recurrence. But it has reduced the CNS recurrences because osimertinib or any other type of the TKIs are having a good penetrance in the brain. By this, osimertinib has reduced the brain recurrence by 80%, reflecting potent intracranial control. And now with the 5-year survival, benefit is around 85% versus 73%. Bottom line is that ADORA has shifted the treatment paradigm, establishing osimertinib as the standard of care in early stage EGFR mutated non-small cell lung cancer. We can see these graphs that the ADORA overall survival rate curves tell us the full story, regardless of the stage, whether it 1B, 2, 2B, 3A, and whether patients received adjuvant chemotherapy or not. The survival benefit with osimertinib is striking and consistent throughout from 1B to 3A. The 5-year overall survival advantage around 10 to 20%. This is the absolute survival benefit, which translates into a nearly 50% reduction in the risk of death. What's the remarkable is the uniformity of benefit across subgroups, 1A, 1B, 2, 2A, and 3A. Now we move to the next case called the ALINA target. The second patient in the previous slide, 55-year-old gentleman who had surgery and was found to have ALK-positive driver mutation. This is the ALINA trial. The ALINA trial is truly practice-changing for ALK-positive early-stage non-small cell lung cancer. In completely resected stage 1B to 3A disease, adjuvant alectinib delivered the unprecedented improvement in disease-free survival with a hazard ratio of 0.24, translating to a 76% reduction in recurrence risk. 2-year disease-free survival reached almost 94% compared to the 64% only. What equally is impressive is that the marked drop in the CNS recurrence, almost 90% or 85 to 90% of the patients who suffer from the ALK-positive mutant disease, they do develop CNS brain metastasis. So this has reduced significantly. Again, the take-home message, the bottom line is that ALINA has redefined adjuvant management, establishing alectinib as the new standard of care in early-stage ALK-positive disease, be it from 1B onwards until 3A staging. I try to share a couple of slides, a couple of graphs. This ALINA trial from the ALINA study. It shows a clear benefit for the targeted therapy in resected ALK-positive cancer. You can see the striking separation of the curves. Alectinib nearly eliminates early relapses. At 2-year disease-free survival over them was 93.6% with alectinib versus only 63% with chemotherapy. Big difference. The hazard ratio was only 0.24%, meaning a 76% reduction in the recurrence risk. Importantly, the overall survival data, which is still maturing, has already shown that it has gone beyond the standard rate of overall survival. Now we move to the third patient. This case exemplifies the transformative potential of targeted therapy in EGFR mutant non-small lung cancer in metastatic disease. We can see from the CT scan finding on the left-hand side that this gentleman presented with advanced disease, mediastinal and hilar lymphadenopathy with multiple pulmonary nodules. After just 4 months on the treatment, in the first-line treatment, we observed a dramatic reduction in the nodal burden and near complete resolution of parenchymal thickening. I wanted to share another patient with you, and I wanted to put her in my slide. But recently she has passed away, so I decided not to mention her. But I just wanted to discuss with you what happened. She was found to have EGFR positive lung cancer. She was gasping for breath. She was oxygen dependent. This lady was meant to attend my clinic, but she was not allowed to come to clinic because she was as an inpatient and she was oxygen dependent. So usually I don't go to see the inpatients to start the chemotherapy or any other treatment. But for her, I went down to see her. She was unable to breathe without the oxygen support. She was at the deathbed. So luckily, on the very same day in the evening, we found that she has EGFR mutant disease. So we started the treatment. On day number 3, she was oxygen independent. On day number 5, she was discharged home. The same woman who was oxygen dependent was about to die. The whole family was around. The priest was around, so that whenever she passes away, the priest does the job. Here we do the Imam Sahib would have done the same thing. So day number 3, she was oxygen independent. Day number 5, she was discharged home. On day number 14, when she came down to see me, she wanted to go back to work. She was a primary school teacher. She was so good, she was mourning that she is not being allowed to drive her car. So that was her condition. On day number 28, she insisted on going on holidays to France. So that was the story. Unfortunately, she although she did very well for 11 months, but now she succumbed to death for some other reasons. I'm coming back to this one. In the metastatic adenocarcinoma, non-small cell lung cancer, the distribution of driver mutation varies significantly between Western and the Eastern population. EGFR mutations are the most... Am I running out of time? I'm so sorry. Okay, I'll be finishing it. My take-home message is that targeted therapy, be it in the adjuvant setting or in the metastatic setting, it has revolutionized the whole mechanism of the cancer biology, cancer treatment, and cancer life expectancy. The outlook has improved, and the quality of life has improved, and the life expectancy has improved. Thank you very much.